Yeah. So we shall now go on to our next speaker, Dr. RONAK Solanki, who's a chief ophthalmologist at the Neo Clarity Eye and Dental Care, Mumbai. And he's got another interesting video for us to see. On to you, Dr. RONAK.
Good evening, everyone. Thank you, Chitra ma'am, for this opportunity. I'll just like to present an interesting case scenario. Hi, this is a case of a 67-year-old female with a mature brown cataract, counting fingers 2 meters. She was on antidepressants and anti-anxiety medicines since 20 years. Was not willing for a surgery, but convinced very hard to undergo the procedure in only eye. Plan was to do a toric SICS because it was a one-night patient. She was very anxious. We wanted to avoid multiple surgeries, so a quick in, quick out procedure with excellent visual outcomes was the key. Treating the patient and not the eye was the goal. The challenge was toric IOL calculation. Precise SIA estimation, which unlike phaco depends on a lot of factors in SICS like wound size, shape, external and internal incisions, toric IOL alignment and rotational stability, along with endothelial protection. Coming to the surgery, 0, 180 toric marks were done. Coming to the calculation, you can see there is a pre-existing 2.04 diopters of astigmatism against the rule. During calculations, a planned SIA of 1 diopter was used and a IOL plane cylinder power of 4.5 giving a residual of 0.3 was used. We had multiple choices of IOL and finally an IOL which gave us 0.35 and 176 was used. Coming to the surgical steps, a conjunctival peritomy was done. Minimal cautery was used. 6 mm guide marks were used for the external incision. You can see them. A slightly larger incision than the marks, like around 7.58 mm was done as an external entry. Sclerocorneal tunnel was fashioned in the way. A meticulous dissection is the key because this is the most important step in the surgery determining your SIA. The internal lips were larger than the external lip. A trapezoid-shaped sclerocorneal tunnel was formed. A slightly anterior entry into the clear cornea is done, which will increase your SIA. Internal lip is extended using a 2.8 keratome. Final sclerocorneal tunnel of a 7.58 mm external incision and 8.5 to 9 mm internal incision is formed. Then a continuous curvilinear capsulorhexis is fashioned. It is a very important step for getting a good overlap with the toric IOL for rotational stability. An adequately sized CCC of around 5.5 to 6 mm is very important. The nucleus management is done with the help of Sinski hooks and an irrigating vectis, and the nucleus is delivered out of the wound. Bimanual irrigation aspiration is done to do a cortical cleanup and the polishing of the equatorial regions and the anterior capsular bag. A hydrophobic toric IOL is placed in the bag and dialed into position using a dialer. Excess viscoelastics is removed from the bag with bimanual irrigation, and a final toric IOL alignment is done before closing the case. You can see that the toric IOL is well aligned with the 0-180 marks. Wound hydration, the conjunctival peritomy is closed using cautery. You can see that the final alignment of the IOL post-surgery. At post-op 3 months, you can see a well-aligned toric IOL with good overlap of the CCC. You can see in the retro illumination, a aligned toric IOL. Post-op, note the new corneal astigmatism of -3.25 and a residual astigmatism of 0.5, which the patient does not accept and is an uncorrected visual acuity of 6.9. So the take-home points for a successful outcome in toric SICS is precise SIA estimation, accurate toric IOL calculations, a meticulous wound construction. Also, achieving spectacle independence is possible. The aim may not always be emmetropia. Reduction in the magnitude of astigmatism goes a long way in giving patients satisfaction and justify using them. Can also plan various EDOFs and multifocal IOLs. Thank you.
Thank you very much, Dr. Ronak. But how do you calculate SIA? You started off with 6 millimeter and it became a 7.5 millimeter incision.
So, usually after doing so many cases, usually a normal SICS would be around 5.5 to 6 mm incision with an internal lip also around 6 mm.
Yeah.
Around the astigmatism which I'm analyzed is around 0.5 to 0.75. When I take a large, so then there's another one which I take is a larger 7.5 to 8 external and 8.5 to 9. They're the only two variations I make because all kinds of hard cataracts will come out through the 8.59. And I've over a few cases I've analyzed it that the SI is usually 1 to 1.25. So I've taken a planned incision of 8 mm and an internal lip of 8.5 to 9. And I've done this for 5 to 10 cases of my toric IOLs in these hard cataracts, just to analyze, because I'm very confident of the SIA that is predictable. It may not be bang on, it could be just 1 or 1.25, 0.25, 0.5 variation. But as I said, with the pre-existing astigmatism of 2, the patient does not have anything to lose. As I said, the aim is not always to target emmetropia. If from 2 I can get him to 0.5, I think it's a fairly good enough job. This case, phaco, but the thing I usually would have phaco, but this was a one-night patient and she was very anxious on antidepressants. She did not want to undergo primary surgery itself. So I just decided to do a safer approach and try out an SICS with a toric IOL.
Now, supposing you are done in SICS, I think you're also, you did a very great job of your surgery. Supposing it had been a hard cataract, your excess would have had become larger. Then doing a with SICS is would not be
this was a point. This was a brown cataract itself. So I've edited the part where I've tumbled it using a bimanual technique. So it's around 6 mm rexis. It's not a smaller rexis. It's a 5.5 6 mm rexis. And mostly, if with a bimanual technique, they will tumble out usually.
Okay. Okay, right. That was nice. Any question to ask from the expert panel, or shall we go on to a last speaker?
Just say that superb surgery, very well documented and very well presented. I was wondering about the SIA, but you gave the answer that it's one diopter. Is it constant? Because some of your colleagues who do a lot of SICs claim that just by the incision, they are able to neutralize the pre-existent astigmatism. They can position, distance the screw incision. The screw incision behaves very differently from the corneal incisions. So any comments on that?
So usually sometimes when there is a with the rule phaco which I have planned and patient is not affording a toric and he has a 1.2, I just do a superior sclerocorneal incision like how I've done this, would probably be a larger sclerocorneal incision. It's mostly I felt that the anterior entry into the clear cornea which matters. Usually in conventional SIs, we would take a 0.5 close to the blue-white limbus, but going more anterior and maybe 8.59, it gives a more predictable reason. As I said, if you want to correct 1.5, you may just end up correcting 1. There's nothing to lose instead of doing a good phaco and leaving 1.5 residual, because with a 2.2 or a 2.8, your centroid and SI would be just 0.2 correcting it, even if you do it on your steep axis.
Great.
Right.
Very good.